Over the last many decades, mental health and physical health have really been in separate silos at the policy, the delivery, and the funding systems. And patients don't exist in silos. Patients don't have this cluster of symptoms over here and this cluster of symptoms over here. So what we are looking to do is bring together all the symptoms a patient may be experiencing and getting them help wherever they are located. Psychosomatic medicine is the medical term that we use for the interface between mental health and physical health. We know that mental illness impacts physical illness. For example, having depression changes the physiology in your body. It changes the physiology of your cardiovascular system, it changes the physiology of your immunologic system, and that impacts other medical illnesses that you might have.
There are these complex interactions between the mind, personalities, and complex physical and medical illnesses. And so what we do, or general consult liaison psychiatrists do, is we're kind of embedded in the hospital system, and we work with other hospitalists and other providers and consultants in the hospital setting, seeing patients who are there for other medical reasons, such as heart attack or stroke or myriad of other medical issues, and they call us in when they detect any type of underlying psychiatric illness. They may have pre-existing psychiatric issues, or they may have developed certain psychiatric disturbances in the course of their hospitalization, and that's when they call us in to help consult on them and treat them and manage them appropriately.
Dr. Smitha Murthy is a psychosomatic psychiatrist who treats people, mental health patients, in the medical settings. She's one of our faculty and has been here for several years, and she's a core faculty for both the general psychiatry residency program but also the psychosomatic fellowship program.
What excites me about being a CL psychiatrist or a psychosomatic psychiatrist is working at that exciting interface between psychiatry and medicine, and working with those complex medical issues and psychiatric comorbidities and helping to treat and manage the patient effectively.
Dr. Lowell McRoberts is the head of our psychosomatic residency program or fellowship program. He is our chief of the service for our integrated medicine.
It's clearly proven that by addressing a population as a whole and working in population health, we can get better outcomes. And so from just a good practice of medicine, I think the integration of the two is key. From a pure practicality point of view, we're not going to have any choice but to integrate the two. There's not enough psychiatrists in this town, in this state, in this country to adequately treat and affect the outcomes of every patient with a psychiatric need. And if we don't have enough psychiatrists to do that, or there's not enough funding sources to provide for enough psychiatrists to do that, then we're going to have to get that care to that population in some other way. And the best way to do that is to integrate with the doctors that they're already seeing. You end up in a place like the Paul Bass Clinic. And so at Paul Bass, for example, we have 20,000 patients who come here as their primary care home. And that's for internal medicine, that's for surgery, that's for some of the subspecialties. You take that 20,000 people, and the psychiatric provider for that population is me, and I'm here 4 hours a week, and that's all that's available. So you pick whatever number of that population you want. Let's say it's 1 in 100 have significant mental illness, and I would imagine that number is actually shockingly low. But assume it's 1 in 100. Then it would take 200 patients who need to be seen by me in 4 hours a week. And if you assume that I can see one new patient in an hour, that gives me 4 patients I see a week, which takes me 50 weeks to go through our entire population without seeing anybody ever again. And so it's a year before I can bring somebody back in for a follow-up appointment, or we try and shoehorn emergencies in wherever we can, and that just doesn't work. And it wouldn't work even if it really was only 200 people who needed our services. And with a number that's much higher than that, it can't go that way. And so that's what we try and do, is integrate our services with the primary team so we can work with them and treat that population.
Dr. Blair Walker is currently a chief resident in our general psychiatry program, but will be entering our new psychosomatics fellowship program this July.
I think that the integrated model of psychiatry and primary care will continue to be a much more common phenomenon. I think it won't be a phenomenon anymore. We work with the nurses, the social worker in the clinic to help them get kind of everything that they need from a mental health standpoint.
In order for us to be able to provide the services that this community deserves, we have to be able to integrate with other providers.
Primary care doctors are on the front lines of psychiatry. They see the vast majority of depression and anxiety, and they treat the vast majority of depression and anxiety out in the world.
Even ancient healers and even Hippocrates recognized there was this kind of important complex interaction between the mind and emotions and medical illnesses. And I guess somewhere along the way, we got a little bit distracted by the scientific method, and then there was this dichotomy of separating out emotions in the mind with actual physical illnesses. But now we're realizing, we're coming back to that concept again, and now we're realizing that there is this, important interplay between the mind and physical illnesses and how they play out.
I'm very excited that as we look at managing the health of a population, we have recognized that mental health is a core component to that success.